Good afternoon, members. I reconvene the Standing Committee on Justice Policy, and I would now call on the Ontario Nurses Association, who are present in front of me. You will have 10 minutes for your presentation. I'll let you know when you have a minute less so you can sum up, and that'll be followed by questions from the members of the official opposition to my left and the government members to my right, and that will be 20 minutes in length. Approximately. Please state your names for the record, answered, and then following that you can begin your presentation. Thank you. Your names, please, and affiliation.
My name is Erin Ariss. I'm a registered nurse, and I'm the Provincial President of the Ontario Nurses Association.
Well, welcome to the Standing Committee on Justice Policy.
Thank you, Chair.
My name is Michelle Bobala. I'm also a registered nurse.
Well, thank you so much for being with us this afternoon. I and my members look forward to your presentation. Please begin, and I'll give you the 1 minute wrap-up time, okay?
Very good. Thank you.
Thank you very much.
Thank you, Chair. As you know, my name is Erin Ariss. I'm a registered nurse, and I hail from Kitchener, Ontario. Thank you, MPP Dixon. ONA is Canada's largest nurses union, representing over 68,000 registered nurses and healthcare professionals in Ontario. And we also represent 18,000 nursing student affiliates. And I want to thank again MPP Dixon for inviting me to share ONA's feedback on this critical topic. IPV is not just a justice issue, but a public health issue, a gender equity issue, a human rights issue, really. And I won't repeat all the statistics mentioned in ONA's submission, but I will say this. IPV's prevalence increases with each passing day we choose not to act. It persists because we are reactive. We need proactive measures. And it is high time that Ontario declares IPV as an epidemic in Ontario. ONA wholeheartedly supports Bill 173, the Intimate Partner Violence Epidemic Act. Using the term epidemic in public discourse will enhance survivors' recognition of their experiences. This is powerful for IPV victims and survivors. But the declaration means nothing without meaningful actions to back it up. Prevention, support services, access to housing, education, good jobs, and related policy changes are crucial to address IPV and effectively support victims and survivors. As a union, we have a duty to protect workers. IPV is not something people leave at home. Following the recommendations of the DuPont inquest, which examined the 2005 murder of ONA member Lori DuPont, ONA has continued to advocate for other nurses, healthcare professionals, and workers experiencing IPV through its participation in the 2017 Violence Leadership Table discussions and the passage of Bill 168. But there is so much more work that we still need to do. Section 32.0.4 of Ontario's Health and Safety Act is reactive. It must be amended to include the actions employers can take to support workers. This includes adopting a safety plan checklist and accommodations measures that account for the unique needs of survivors and victims. We have an excellent resource for employers on addressing IPV, the Violence, Aggression, and Responsive Behaviors VARB toolkit. However, the Ontario Health and Safety Act and the VARB toolkit do not mention work-from-home employees. In fact, work-from-home employees need additional support to deal with IPV. Work-from-home employees cannot be an afterthought. We must make relevant changes to the Ontario Health and Safety Act and the VARB toolkit to protect all workers. Workplaces are where perpetrators and abusers target victims and survivors. There is a higher risk of IPV for workers in public settings, such as hospitals. We need a province-wide relational security model to protect workers. Lastly, current domestic sexual violence leave offered by the provincial government is not enough. We have included recommendations for the subcommittee to consider improving paid leave for IPV employees. Survivors and victims should not have the added burden of worrying about finances. As the president of ONA, I represent workers first and foremost. Hence, I spoke about protecting workers dealing with IPV. Now I'll speak to you as an Ontarian. IPV impacts workers and non-workers alike. And I urge the subcommittee to take action to support survivors and victims who do not work or earn less, and to recognize that women of color, Indigenous women, newcomers, women living with disabilities, trans and gender diverse folks are statistically most likely to be vulnerable to IPV. If we cannot protect the most vulnerable, we will fail in our endeavour all over again to protect Ontarians. I'll now pass it over to my colleague, Michelle Bobala, who is also a registered nurse, and Michelle will shed light on the role nurses play in supporting IPV survivors and victims, and more importantly, the systemic changes that are needed to support their patients and end the violence.
Thank you, Erin. So as mentioned, my name is Michelle Bobala, and I am a registered nurse. And I work as a forensic nurse and a sexual assault nurse examiner at a sexual assault and domestic violence care center in Toronto. We provide care to individuals who have experienced sexual assault, human trafficking, and domestic or intimate partner violence. Most of our patients are women, but we also see men, trans, and non-binary individuals. As forensic nurses, we provide care plans for patients on a case-by-case basis. We specialize in crisis intervention and forensic and trauma-informed healthcare services for survivors of sexual assault and intimate partner violence. We provide care to patients up to 30 days following a sexual assault. In these cases, we offer sexual assault evidence kit collection and documentation, STI testing, toxicology testing, STI prophylaxis, emergency contraceptive options, and other forms of care. In most cases, supporting victims and survivors of sexual assault requires 4 or more consecutive hours of one-on-one nursing care for each patient due to the complexity of the care being provided and the need to complete thorough documentation that might be used in criminal justice proceedings. We also provide care to patients who are experiencing domestic or intimate partner violence. Here, we provide care within a broader treatment window, and the care offered includes providing emotional support, documenting assault and abuse history, assessing and documenting injuries, taking photographs, and connecting patients to community resources such as trauma counseling and shelter supports. There are not enough nurse examiners available in Ontario right now to support clients when they need it. As a result, there are significant gaps in patients' ability to receive forensic and trauma-informed care from a specially trained nurse examiner, in particular in northern and rural and remote communities. There is an urgent need for the Ontario government to support the expansion of the Ontario network of sexual assault and domestic violence treatment centres and hire more forensic nurse examiners. We are the first member of the healthcare team in contact with victims and survivors of violence. When someone experiences sexual assault, violence, or abuse, it is crucial that they have access to the necessary supports and services. But that is simply not the case right now. Many of the victims and survivors we see do not have access to primary care providers. This means they don't receive the ongoing health care that they require. One of our recommendations is to expand the RN scope of practice so we can make referrals to improve our patients' access to primary care. For example, survivors sometimes require a referral for gynecology, psychiatry, or other specialty mental health services. If we could make these referrals, survivors would have better access to the support that they need. Lastly, we urge the government to fund and improve access to mental health services and safe shelter
Excuse me,
beds.
you have 1 minute left. Thank you.
There are substantial wait times to access counseling through the sexual assault and domestic violence treatment centres, through hospitals, and in the community. And there is a severe lack of safe, supportive housing and shelter beds for victims and survivors when they are trying to escape an abusive situation and find a place to stay. These services must be available to support victims and survivors, but these services are inadequate or do not exist. We care deeply for our patients. We cannot support them when the services they need simply are not available. We hope the subcommittee can action the recommendations we've discussed today. We look forward to your questions. Thank you.
Well, thank you very much for your presentation. We're now going to start with the questions from the official opposition members. And I have MPP Sadler, please, and thank you when you're ready.
Thank you very much, Chair, and thank you so much to ONA for coming to us today and for making your presentation. In particular, I want to thank you for your written brief and the recommendations that you include. Well, number one, your endorsement of declaring the epidemic, your support for Bill 173, but also your recommendations really kind of highlighting the fact that many of the solutions are already there. They're there in the recommendations from the Renfrew County Coroner's Inquest, from the DuPont inquest, from other expert reports that have already been presented to the government. So I think that's a really important part of your presentation today. I wanted to dig a little bit deeper into your recommendations concerning occupational health and safety, because that's something that we haven't heard a lot about so far in this committee. As a MPP, I brought in the original private members bill to create paid leave for domestic violence and sexual violence. So really appreciate your thoughts on how that can be strengthened. We did hear a presentation yesterday from Women Act in Toronto. They raised a concern that not enough people are aware that those protections exist in the Employment Standards Act and that people can access that leave. So if you could just sort of expand a little bit more about the changes that can be made to the Occupational Health and Safety Act, and also a little bit more about the paid leave provisions for DV and SV that's in the Employment Standards Act.
Thank you. I'll answer that question. So we do know that Section 32.0.4, as we referred to in our submission, is proactive rather than reactive, or we want it to be proactive rather than reactive. And it says here, and include minimum actions that employers must take as part of minimum precautions. What we need to see is that the act is, if an employer becomes aware or ought reasonably to be aware of domestic violence, that they will take these actions. We would like to see safety plans mandatory, of course, put in place. That safety plans are comprehensive, that the worker is aware, that training takes place. What we're seeing now is that information is circulated, but there's a difference between providing information and training workers on safety plans. And of course, that is the number one thing we would like to see. The ESA for the leave, we know that it's cumbersome to access, that 1 day of a week can be considered 1 week's leave. It should be paid. It should be 15 weeks at a minimum in length, and it should be widely available to victims, survivors, and those who've experienced this broadly. So we have seen leaves like this in the past, and in other jurisdictions as well, I understand, and we would like to see that in Ontario. That we also know that victims and survivors that is a barrier to seeking safety, that they are financially constrained, and that power dynamic need not exist, or we need to do our best to limit that.
Okay, thank you very much. The other questions I had were around the SANES, the sexual assault nurse examiners, And Michelle, you had commented or raised the concern about the shortage of these positions across the province. Can you tell us a little bit more about why that is? Is it because of the need for increased funding for the sexual assault, domestic violence treatment centers? Are there other factors at play? And can you just expand a little bit about the importance of having these positions in our hospitals in Ontario?
Absolutely. So, as I'd mentioned, the care that we provide takes, minimum 2 hours, 4 hours, sometimes 6 hours to do. This is not a role that can be added on to, the already very overburdened emergency department care providers or to primary care. It is a very specialized role that then has ramifications in the criminal justice process as well. Injury documentation, assault history, all of these pieces need to be very carefully, meticulously documented, and that's certainly not something that, currently, especially in the emergency departments that are so understaffed and overburdened at the moment, could possibly take on. And there are insufficient programs across the province. In more remote communities, it could be several hundred kilometers before someone can actually access a program. And even in more urban centers, the nurses are often only paid as on-call as opposed to part-time and full-time roles. And so it's very difficult for some of the existing programs to even maintain their staffing levels because a nurse cannot survive on an on-call model that is unpredictable. May get called once and then another time in 2 to 3 months again, and also potentially lose their skills over time, right? And one of the issues too is that we're not really able to even determine how many people are not able to access that service because we can't document that. How do we document when there's not a sexual assault nurse examiner available when someone went to the emerge to try to access that care? Who is keeping that statistic, right? We just don't know. And so if we could have 24/7 access to sexual assault nurse examiners like we do in some programs, then the level of care will be much better and survivors will be able to access that care and access to justice in a much better way.
Okay, thank you. And then my final question is around prevention. So you talked a lot about the role of nurses in responding to cases of IPV or sexual assault. What role can nurses play in prevention of IPV in Ontario?
Yeah, excuse me, that concludes the time for the official opposition, but we have another round. So you might wish to put that question in the second round. And now we go to the government members, and I have MPP McGregor, sir. Please, when you're ready.
Thank you, Chair, and through you, thank you to our friends from the ONA for being here, and not only being here, but the work you do on behalf of your members. Just MPP Sadler's question.
Do you want to?
Sure. So I think one of the issues is that screening is not happening to the level it could be because of a lack of comfort and experience. It's a very sensitive issue to talk about. A lack of time. Nurses and healthcare providers need to be building trust in order to elicit those disclosures, and they don't typically happen on a first inquiry, especially if a relationship of trust or a rapport hasn't been built yet. And in the current state with nurses just being so overburdened, not enough staffing in the hospitals, there's just no time to really do that, and that relationship can't be built in such a short amount of time when nurses have so many other clients to be taking care of. And the other important piece is that what are we doing with that information when we receive it, right? If we don't have the available services to refer folks to, then we can screen and we can try to prevent and action in advance. But if we don't have anywhere to direct the client to, it borders on dangerous, because if we do send them off to a shelter or to some counseling supports or mental health services, and they get denied because there's no space, or because there just isn't a center in that region, or there's a 8-month to 12-month wait list for counseling, that will really shut down a survivor and will really make it unlikely for them to be able to seek help when they're really ready, when they're coming forward. I fully support, further screening and trying to prevent violence and get ahead of it before it becomes very severe for survivors. But we simply can't be screening and then not having the services to support clients.
That's a topic we've heard about. I think we're day 8 of our study here, and something we hear time and time again are the survivors that are, I guess we're kind of losing. That it's imagine the courage it takes to put your hand up once and to ask for help, but then when you have to get mental health services here, and you need family counseling here, and you need addictions work over there, and support to flee a dangerous situation is go line up at that desk down the street, kind of like the amount of people that we're losing. I think we're hearing that time and time again. One of the ways that we hear, so in my region, I represent North Brampton. In Brampton, we have the Safe Centre for Peel, where survivors can access support. There's mental health services, family services, the police, the Peel Police Unit. It's all in that kind of same building. We've heard of that as a model to replicate, certainly in urban areas. We've heard that's different in the rural context. But I guess from the ONA's perspective, our hub models, is that a helpful thing that we should be rolling out more? Where do you think that's helpful? And how can government take leadership and ownership to actually create these hub models across different communities, given the fact that it's Safe Centre for Peel happened generally because agencies got together and did it themselves. Like, it was a very bottom-up approach, not a top-down approach. So your advice on how government would do that and mandate that top-down if that's a direction they were going to go in?
I think from ONA's perspective, provincially, we've supported localized community health care. So a hub philosophy is something that we could support. Staffed by the appropriate staff, of course, registered nurses and experts in this field. To have it in one center is excellent, in one urban center. But when we look, and Michelle spoke about this earlier, rural areas, geographically, that will be difficult, but it's not impossible. And certainly all Ontarians deserve the same level of care. So it is a mountain to climb, but I'm certain, together we could make sure that all Ontarians receive the care they need.
Yeah, and it's one of the challenges in the space from a governing perspective is the need to respect regional contexts, but then how do you ensure stability of service in different regions that have different needs and different, even just different capacities from a HHR perspective and that kind of thing. I wanted to ask, you talked about the need for more nurse examiners. Do you have a sense of, or does the ONA have a sense of how short are we on nurse examiners? How can we recruit them more? And then a follow-up, which I can remind you of, because I know I've asked kind of big questions, but another one would just be what province is doing it well and who's doing it well and who should we copy? But I guess how big is the shortfall and how can we make it better? What can we do to increase recruitment?
There are vacancies across the province, but Michelle can go ahead as she works in this role.
Beautiful. Thanks.
I believe you'll be speaking to some other experts on this, such as the director of the Ontario Network of Sexual Assault and Domestic Violence Treatment Centres. So I'm sure she will have some very good ideas about this. I think the expansion of programs is a starting point because there are only 37 centres in all of Ontario. Ontario is a vast province. The other issue is the funding. There's just not been funding appropriately allocated, right? We are, for example, in Toronto, we do have a model where we have full-time and part-time staff. but for a region of over 5 million people, we have the equivalent of 5.2 FTE, so the equivalent of basically 5.2 full-time staff for an enormous number of people. Other programs don't have that model. They don't have a full-time nurses there. They're on call, and they cannot always staff those shifts. So there are days where even in one of these 37 programs, which could be expanded, they don't have a nurse available. So I think funding is a big piece of it, and then making those roles actual roles that someone can take, as opposed to just having to do it in addition to other work, because then it can't be prioritized.
Who, of other jurisdictions, Canadian provinces or maybe even states, I guess if we're looking south, like who's doing this well? Who should Ontario replicate?
I think Ontario is doing it well, and like the network is doing a great job with the resources that they have. I can't speak to, I'm not an expert on other regions, but I know where we're short. Where even within a context of having 5 nurses, it's been very difficult, to provide care adequately to patients when they need it. We had a sick call last night, and we had nobody on, so it's just by the good nature of other nurses that were willing to take an on-call.
Thank you very much for that response. We're now going to go back to the official opposition for MPP Wong Tam. Please, when you're ready. Thank you.
Thank you, Chair, and thank you to the ONA reps for being here today. As I was trying to remember the Toronto Public Health nurse that we had lost in 2015, largely due to domestic violence, homicide, her name was Zara Abdil, but when I looked up nurse and IPV, nurse and domestic violence, there were 4 other names that came up just in recent history, Lori DuPont being the other one, Shannon Hickey and Susan Chen. So your association has lost a number of members, and these are the ones who have fallen permanently, not including members, because it is a woman-dominated sector, who have been harmed and injured but not necessarily reported and not killed. So I recognize that this issue is very deeply personal for I think many of the nurses that I've spoken to, but I also just want to say thank you for coming to the committee to speak to us today. I want to unpack the ONA membership in clinical settings, because we have, aside from the fact that there are not adequate rape kits, that's one thing. Aside from the fact that there are not enough forensic nurse examiners, clearly that is another deficiency. But when it comes to ONA members in the clinical setting, how do they see themselves as it relates to the issue of IPV, and how can government do a better job of supporting them so that they can do their job of reporting and identifying it at early detection?
I think we both probably could tackle this one. I worked for 20 years at St. Mary's General Hospital in Kitchener. It is the regional center. I can tell you I triage thousands and thousands of survivors and victims of IPV. That was my job. To do my job better, we need adequate staff. We need adequate time. My job was different than Michelle's, that a patient presents and I do the screening, the initial screening. But there are barriers to that. And I can't really go into that publicly and how we resolve those barriers, and we get quite creative to protect our patients. But ultimately, we need more time. We need privacy. We need security to do that, and the time to build relationships and trust. Michelle, did you have something else?
Thank you very much for that response. We now need to move to the government, please. And MPP McGregor, sir, when you're ready.
Thanks. Just Michelle, if you did want to add to that answer. Want to give you the time.
In our role as sexual assault nurse examiners, we also do provide education to emergency departments on ways to identify survivors who have not yet disclosed. They're coming in for STI testing, they're coming in for injuries that are suspicious, but they're not disclosing the violence. So this is education that should be provided and should be mandatory, across all hospitals in Ontario, not just these regional programs that are doing that, with the limited staffing that they have. encouraging education, promoting education that's trauma-informed, making sure that we're not re-traumatizing patients, not making them afraid to come forward in the future, because sometimes, we subscribe as a society to myths and stereotypes about intimate partner violence, sexual violence, that can be very detrimental, and then patients don't seek the care that they need. So education is a very important piece of that.
Is intimate partner violence and signs of I guess training to see the signs of it. Is that part of the curriculum, like the nursing curriculum, or do you graduate and it's
been several years since I've.
I don't know currently. What I can say to you it is an advanced skill that a novice nurse. That certainly emergency departments are often the first point of contact. The triage nurse has been or should have been employed full-time in an emergency department for 2 years prior to taking on that skill. Right. So you need advanced assessment skills. You need to be able to build trust quickly with your patient in order to screen and get disclosure.
We've heard about, we heard from the Coalition Against Human Trafficking in a similar thing, and they are different signs, I guess, for different contexts, and sometimes involve the other, but training around identifying signs of human trafficking, is that something you think would be helpful and help solve the problem?
Yes.
If that was training that nurses received as well?
There's inconsistent training right now. It's not happening in every center across Ontario.
So it's happening regionally, but it's not consistent across the board.
That's correct.
Thank you very much. That concludes the time that we have for your presentation. Thank you so much for being with us this afternoon.